This is the 10th of the series of www.survivingmold.com discussions. Richie Shoemaker, MD, will discuss laboratory diagnosis of a chronic inflammatory response syndrome, Part 1.
Good morning. Use of laboratory studies is essential in not only documentation of the presence of a CIRS, or chronic inflammatory response syndrome, but is also mandatory for following the effects of treatment of CIRS. We receive questions on a daily basis from patients having trouble accessing particular tests, with New York State leading the list and Florida not too far behind with labs that have some concerns. Specifically, the list of lab codes and specimen handling requirements is listed in the diagnosis section of the Surviving Mold website, with discussion of laboratory studies and then interpretation of those studies. I'd like to go over just a few of the tests that we use routinely, understanding that this might take more than just a couple minutes. We'll try, so bear with me. The first test to pay attention to is the immune response gene haplotype called HLA-DR. This is analyzed usually in LabCorp, but can also be done in Quest by a mechanism that looks at PCR using SSOP technology. I don't think you need to use all those acronyms, but someone, say in Idaho or Arizona, may want to know. So it's HLA-DR by PCR. This is a test that's done in whole blood, kept at room temperature. It is sent to look at particular DNA sequences. Sometimes we see people having an interest in HLA-DR getting HLA-B27 tests. That's not the same. Narcolepsy tests, not the same. Gliadin problems and celiac disease, not the same. It will give us HLA-DRB1, DQ, and HLA-DRB3, 4, and 5, all in one assay. This particular grouping of genes helps us compare what a patient has to a known registry that's been published covering over 10,000 patients, period. We have so many different HLA haplotypes now with the explosion of technology that the older nomenclature is somewhat out of date, and yet the basic idea applies, that we can look for susceptibility to a given illness, whether it's post-Lyme or mold illness, for example, understanding that there will be a select group of haplotypes found in those illnesses over 95% of the time. Of the illness presence of the immune response gene haplotypes in the general population, about 24 to 25% of patients will have mold genes, so-called mold genes, and then 21 to 22% will have those associated with post-Lyme. If there is presence of genetic susceptibility, what we also look at are two of the neuropeptides. Alpha melanocyte stimulating hormone, or MSH, is one of the tests that we have the most experience with. We use LabCorp now exclusively for MSH. We've tried to get Quest to use the ALPCO, ALPCO kit to do the alpha MSH determinations, but unfortunately have not made headway along those means. Specifically, the normal range for alpha MSH is 35 to 81. You'll see LabCorp presenting a normal range of 0 to 40, and on the surface of that should be a little silly. We need MSH to live, and a level of 0 is not compatible with life, but that's for another day. The MSH controls the immune response gene activity as far as uncontrolled inflammation. It also will look at any number of cytokine abnormalities, mood disturbances, and a host of others. The second of the regulatory neuropeptides beyond MSH is VIP, or vasoactive intestinal polypeptide. Please see the paper published on the resources section on use of VIP It'll tell you not only what it is and how it works, but what a spectacular addition VIP has been to our treatment armamentarium. In part 2, we'll go over more studies of significance for people with CRS. Thanks so much.